All right. Welcome, everybody, to Cardiovascular Medicine Grand Rounds. It's a great honor to introduce today's speaker, one of our phenomenal cardiology fellows, Dr. Ahmed. Received his medical degree from the University of Khartoum in Sudan. He then completed his internal medicine residency at Detroit Medical Center, Wayne State University, which was followed by a critical care medicine fellowship at Mayo Clinic in Rochester, Minnesota. He then joined the University of Michigan for his cardiovascular disease fellowship in 2021, and he's currently a third-year fellow and currently his last year. He will be moving to Cleveland Clinic for an advanced cardiac imaging fellowship. I've known Dr. Ahmed well. We worked together in the echocardiography lab. He's very thoughtful, dedicated, and a caring physician. I always welcome his calm and relaxing demeanor. He's always attentive to details, and he's trying to understand always the underlying reason why we see things in the echocardiograms. Dr. Ahmed is interested in the role of biomarkers and cell damage that is placed in critical ill patients in the intensive care unit. He will be discussing today about myocardial injury in critically ill patients.
Thank you, Dr. Mollis. Thank you, everyone, for being here. It's certainly the honor is mine to stand at this podium and present this overview of myocardial injury in critically ill patients. A topic that I do believe is very important. We're getting more and more information about the pathophysiology of myocardial injury every day, but more importantly, we're getting more and more patients with this pathophysiology. Certainly, it sits at an intersect between many specialties, so cardiology, internal medicine, critical care medicine, emergency room medicine. And we tried to invite stakeholders from different fields today, and hoping that this is going to be an engaging and interactive discussion. I have nothing to disclose. And please be ready to use the Slido app for the poll in the first few questions and cases that we're going to use, and just use the barcode or use the website. And once we get to the slides, it should hopefully work smoothly. So the objectives today, I want to revisit the fourth universal definition of myocardial infarction, highlighting how the kind of subtle differences in diagnosing myocardial injury versus myocardial infarction. Obviously, because this is a myocardial injury discussion, we have to talk about troponins with an emphasis on high sensitivity troponins. And then I'll talk about some mechanisms, also at the molecular level, of how to explain why troponins are released in patients without getting irreversible cell damage, without cell necrosis. And then I would like to highlight some of the challenges in the management of myocardial injury and some of the gaps in the care of these patients. I'll start with the first case. This was an 82-year-old man, has history of atrial fibrillation, moderate aortic stenosis, carpal tunnel syndrome, comes to the hospital with chest pain and hypertension. This was their second hospitalization with the same symptoms in the last 4 months, and they recently had a left heart cath with a coronary angiogram like 2 months ago with the same presentation that showed non-obstructive coronary artery disease. Their systolic blood pressures were in the 80s when they first came in, responded to IV fluids. You can see their medications, and the high sensitivity troponin was 46 on admission, and in 3 hours, it was up to 66. Their EKG did not show any evidence of ischemia, and the bedside ultrasound showed normal LV systolic function and normal wall motion. And so the first question would be, how would you classify this increase in troponin from 46 to 66? Would you say it's an acute myocardial injury, chronic myocardial injury due to heart failure? Is it a type 1 or type 2 MI? And let's see if it's working. I'll give it like maybe 20 seconds and then, okay, right, great. I think people are still joining in, and yeah, you can always change. This is a one answer question, but yeah, so seems that we have kind of split between, is this an acute myocardial injury or a type 2 MI? Okay, great. Come back to this. A second case is of a 65-year-old woman, comes to the hospital with septic shock, pyelonephritis. She does have history of heart failure with reduced ejection fraction. In the emergency room, she gets intubated because of inability to protect her airways and gets admitted to the medical ICU, initially on low dose of norepinephrine. And during the ICU stay, she gets an episode of hypotension requiring increase in the norepinephrine, initiation of vasopressin and stress dose steroids. Her EKG is normal, and her high sensitivity troponin initially was 60, and after a few hours on the repeat, it was 70. Again, same question. Do you think this is acute myocardial injury due to sepsis or potentially to the catecholamines? Would you think this is chronic myocardial injury due to heart failure, acute myocardial injury due to volume given to the patient, or type 2 MI, or could potentially be all of the above? So just give you 15 to 20 seconds to join in. Okay, so some responses are coming in. Acute myocardial injury due to sepsis. Some say all of the above, and type 2 MI. Okay, great. I'll just see some more votes coming in, so we'll just give it another 5 seconds. Take it from there. Okay, we'll revisit this as well. The final question is, 48-year-old man comes to the hospital with intractable vomiting and agitation. Has history of alcohol use, and there's concern for alcohol withdrawal. Patients also get intubated in the emergency room for inability to protect their airways. And because of a high COR protocol, they get admitted to the medical ICU, during which time their blood pressure is normal. And surprisingly, the other vital signs were within normal limits. The high sensitivity troponin was 220. After 2 hours, it was 210. And then the last was 198. And this is his EKG, no significant evidence of ischemia. And here, this is a multiple choice, so you can pick as many options as you can. So just basically someone comes in with alcohol withdrawal, there's elevated troponin, and you're asked to see what would be your approach to this. Would you start aspirin and Plavix, heparin, high-intensity statins, beta blockers, ACE? And great, so we have options coming in. Continue to observe with no further intervention. Great. Okay. So responses coming in, starting aspirin, high intensity troponin. Okay, I think like the last one had like maybe 11 to 15 responses. So I'll just wait for a few seconds and then take it from there. Okay, great. So it seems that most people would observe, but there is a spread between what to do. And let's start the discussion. This last question, let me see. Okay. Make sure. Okay, great. So this last question was, there was a survey. Sorry, I think the top part is kind of covered. So I'll just try to. This was a survey a few years ago where they surveyed 300 intensivists in the United States, and they asked them the same question. If you had someone in the medical ICU who had high sensitivity troponin elevated without chest pain, what would you do? And it also included cardiac intensivists as well. And they gave them multiple choices, as we just did. And so you can see that there was also similar spread to what we had in our poll. It seems that the majority said that they would start aspirin or Plavix. There's 70% said they would consult cardiology. And then there was different interventions. About 50% said they would start heparin, high-intensity statins, and potentially beta blockers. And there's 50% who said, we'll send the patient to an angiogram once stable. And so this is really to highlight that there are no clear guidelines to guide people in the management and the treatment of these patients. And so there is definitely a knowledge gap, not only from us in healthcare, but also like just the literature is not clear about this. So I'll talk about myocardial injury. The definition of myocardial injury on the fourth universal definition of myocardial infarction is that you have a high sensitivity troponin above the upper reference limit, which I think in our hospital, the normal is 0 to 20, so anything more than 20, but it's usually gender specific, anything more than 10, anything more than 15. What I want to highlight is this upper reference limit, the 99th percentile, is basically the FDA asks the assay providers that they test the troponin in normal people. So they bring in healthy volunteers, 400 males, 400 females, and they check the troponin. And the troponin usually is detected in these patients, in these volunteers who are presumed to be healthy. And then they do 3 standard deviations above the mean, and they get this upper reference limit. And so first thing is high sensitivity troponin in healthy subjects or presumed healthy subjects without risk factors, without diabetes or hyperlipidemia is detectable. And so if there's a rise or fall in troponin, then this is acute, as we all know. If there's no rise or fall over 8 hours, then it's chronic. And the question is, what is a considerable rise or fall? Like this delta that we're looking at, what is a significant delta? Is it 10 points? Is it 20 points? Are we using percentages? Are we using absolute numbers? And this also is something especially in the ICU, is very important. I'm going to try to revisit that. So in order to understand what is a significant delta, we have to understand some of the variation in troponins, the normal variation in troponins, because you want to make sure that whatever delta that you're making your judgment based on is not due to chance or not due to other causes of variation. And so the 3 factors that we look for in variation are the pre-analytic variation, and this is really how you collect the sample, store the sample. There are some patient-related factors that can affect the troponin levels, including fasting status and whether you collected the sample from a central line or a peripheral line. And so this can add to a percentage in the variation in the troponin level that you get. The other factor is the analytic variation, which is basically if you get the same sample and you run it with the same kit provider, the assay provider, every time you're going to get a different troponin level. And that's just normal and that's expected. The FDA puts this is called the coefficient of variation. It should not be more than 10%. So you'd always expect that there will be a 10% change because of the analytic variation. And probably the most important these days is the biologic variation, which means that if you take the sample from the same patient 1 hour, 2 hours, 3 hours apart, weeks apart, there will also be variation. And if you take the effect of pre-analytic variation, analytic variation, biologic variation, the guidelines say that the combined effect of all of these variations can be up to 50 or 60%. So you really want to look at a change in the troponin more than that, and I'll come back to that in a few slides. This is just to show you, this is a study that was done in Mayo Clinic. They looked at the biologic variation in presumed healthy subjects, and they checked their troponins on the left side. They checked the troponins every hour for 4 hours. And for example, if you look at subject number 13, you would see that their troponin levels during this time period had a variation between 1 nanograms per liter all the way to 3 nanograms per liter. They also followed these same presumed healthy subjects for 8 weeks, and they were checking their troponins every other week for 8 weeks. And you can see, understandably, the variation is even more pronounced. For example, subject number 6 here had a variation between 4 nanograms all the way up to 13.5, which actually puts this patient in the myocardial injury range. And so again, the combined effect of all of these variation factors is about 50 to 60%. And so the guidelines recommend that in order to call a delta significant, you want to see a change that is more than 50 to 60%. And this is specifically true if the patient's initial troponin is very low. If the patient has chronic troponin injury and the troponins are kind of chronically high, you might not be able to pick a delta if you use 50%. And in that situation, usually it's a 20%. And I think like a lot of the patients that we have will have their initial troponin value detectable maybe 12, 20. So probably this 20% change is relevant to our practice. We must have all seen this slide before, but just to kind of summarize what I just talked about. So you have this 99% upper reference limit. You can see that this curve of the troponin elevation after myocardial injury, it's very steep here. So you can use absolute changes. Like you can say if it was 12 and then it's 24, then that's like almost doubling. So it can be good to use absolute changes at low values. But as you increase the value, these 10, 12 changes are not going to be that significant. And so usually when the values go up, you look for a percent change. The other thing that I want to highlight is the troponin curve, when it descends, it actually descends very slowly. And so even in our patients with myocardial infarction, if the patient's symptoms started maybe 24 hours ago or 48 hours ago, you might not be able to pick up the delta because they'll be on this descending part of the curve. But in general, especially in when it's infarction, the curve goes very steep ascent and then very slow descent. And that's also important when we come and talk about different other types of injury. So I want to highlight how common is myocardial injury. And so I picked a few examples from the literature. This is in the medical ICU patients. The patients were not admitted for cardiac causes. And you can see that 75% of the patients had a troponin elevation above the upper reference limit. So they did have some evidence of myocardial injury. This is similarly in a different study, it was 54%. And obviously there is variation based on the patient population that you're looking at. So what is the prognostic value of myocardial injury? And specifically in critically ill patients. If you look at different patient populations in the medical ICU, GI bleeding patients, usually their long-term outcomes, if they survive the ICU stay, their long-term outcomes are worse. This is after you adjust for their other risk factors, the severity of illness during ICU admission, SOFA score, you still have an independent worsening in their outcomes in 2 years. And surprisingly, or maybe not surprisingly, didn't show any short-term outcomes association. In patients with acute respiratory illnesses, you can see that the risk of death was high after 2 years or also within 30 days. So there's short and long-term outcomes are worse. But that should not be surprising because this study that I'm showing you is actually a study in, again, presumed healthy subjects. This was the PROSPER trial where they were looking at effects of statin on population, I believe in Sweden, and they followed up these patients for 11 years. And what the researchers in this study did, they collected high sensitivity troponins in these patients, and they just followed them up for 11 years. And you can see these red dots. They kind of split the patient population that they had to different levels of troponin elevation. So they kind of used interquartiles. This is the highest quartile that was in the myocardial injury range. And you can see that these patients just has worse outcomes. They have more cardiovascular disease, more coronary artery disease, and more fatal cardiovascular events. This is in normal people walking on the streets without any risk factors that we know of. And this is kind of to highlight this again. These are the hazard ratios for these patients, and you can see that there's a significant increase. Okay. So I want to talk about how is troponin released from injured myocardium. And this will be the first time in the presentation that I'm talking about myocardial infarction. And I'm intentionally trying to use the word myocardial injury just to show that there's a big umbrella of pathologies that can affect the heart and not to focus so much on myocardial infarction. However, I'm bringing this up because initially when we're using troponin, our thought process is that you're having enzyme that is released from myocardial cells when the cells die. And so now with the high sensitivity troponin, we're picking up less and less troponin values, and in situations that we know this is not a myocardial infarction, this is not cell necrosis. So I'm going to use what happens in cell necrosis first, and then we'll see other possible mechanisms. This is the troponin that we know of. The things that I want to, is obviously the troponin is a protein that's connected to the actin and myosin filaments, and it kind of modulates how the myocardial muscles contract. The one thing that I want to highlight is that most of the troponins, as we see here, is attached to the actin and myosin filaments, but there's a little bit of troponin that is, we think of as kind of loosely attached to things, and so it's in the cytosol, and that's usually less than 8% of both troponin T and troponin I. And so when you have an extended period of ischemia, usually more than 20 minutes or so is when we're thinking you're having a myocardial infarction. There is all of these changes in the cell, the pH, it changes, and then this gives disruption of the membranes, intracellular calcium increases, and basically this activates a lot of proteases, and the proteases end up degrading the troponin that is attached to the myofibrils. This degradation takes time, it's not instant. And so when you take into consideration these two concepts, is that you have troponin sitting in the cytoplasm. This troponin, when there's myocardial injury, it does not need to be degraded. It doesn't need the effect of the proteolytic enzymes. And so it usually is released into the circulation early on. And that gives you that ascent, the quick ascent. And this is probably the troponin that we pick up in the first 2 hours. After that, the proteolytic enzymes, if the ischemia in this situation, which is the injury, is still sustained and is not fixed, then the proteolytic enzymes are kicking in, and then you're going to have this kind of a second phase of troponins that go into the circulation. And that really gives you that slow descent into the circulation. So this curve, the way it's looking, this is exactly how you expect myocardial infarction troponins to behave. However, in the ICU, we see patients with very high troponins, and we do cath eventually. They don't have obstructive coronary artery disease, and in ways that you can't really explain it by cell necrosis. And I'm gonna kind of highlight a few of these examples that we see in the ICU and kind of just revisit that. The first one, this is maybe not exactly in the ICU, but it's still relevant. This is a study about stress testing. And this is, I think, in Boston. They made the patients have nuclear stress tests. They were able to interpret the results. Some patients had no ischemia, some patients had mild ischemia, some patients had moderate to severe ischemia. And they just collected their troponins before the test, after the test, 2 hours and 4 hours later. And these are brief episodes of ischemia, if any, but you can see that the troponin definitely at 4 hours was statistically significant, was elevated. You cannot explain this by cell necrosis, obviously. Similarly, this is kind of, again, just kind of, we're stressing the same point that the cytosolic pool of troponin could potentially be spilling in these brief episodes of ischemia without the need for cell necrosis. Another study was dobutamine. It was a dobutamine stress test in 10 healthy volunteers, but this is also relevant to the ICU because we use a lot of vasopressors, vasopressive medications and inotropes. And again, same concept. You have people who are coming in for a stress test. They check their troponin levels before the test, and then in 30-minute intervals after the test. And you can see that by 4 hours, there is a significant elevation in troponin. And it was quantifiable. So people who had wall motion abnormalities on their echoes had higher elevations in troponin. But the message is, after a stress test, you would expect some elevation in troponin, and that does not necessarily mean that the patients have a myocardial infarction. Other scenarios that we see in the ICU is use of norepinephrine. And there were several studies in the literature that is also highlighting that. This study was, I believe, in a canine study that infused the canines with norepinephrine or isopretinol, and then they did histopathology examination of their heart. And after 60 minutes or so, you can see that they describe there is some subendocardial hemorrhages. There's a group of changes that happen in the myocytes that they called coagulative mycocytolytic changes, which is basically a lot of intracellular calcium, a lot of contraction bands. And it was also quantifiable. So more contraction bands associated with more troponin release. So these patients got norepi. They had evidence of histopathologic changes showing cell injury, and they had elevations in their troponin. And so that's another intervention that we do in the ICU that can contribute to myocardial injury. Other studies are showing the effect of sepsis. We know nowadays that the inflammatory markers play a big role in myocardial injury. And I would just highlight the red and the blue line. These are ICU patients along their length of stay in the ICU. And again, you can see that interleukin-6 in blue and troponin also, they increase together. After you do multivariate analysis, take other confounding factors, there was still a clear association between these two. The study group concluded that an increase in interleukin-6 by one standard deviation increases the high sensitivity troponin by 25%. Another intervention that we do in the ICU that was also studied, I do believe this was a study in rats, and again, atrial pacing. And again, after pacing for 60 minutes, you can see that the troponin, whether in the coronary sinus or in the peripheral blood, was increasing. In all of these scenarios, you cannot explain it by myocardial necrosis. So this kind of brings the question, if it's not cell necrosis, then what is the reason of the troponin elevation in these patients? And I'm going to talk about some of the theories, and a lot of them are proved now that can explain this. The first mechanism is B.B.S formation. And this kind of goes back to what we just talked about, is you have free troponin not attached to the myofibril apparatus. And so when you have initial injury, even if it's an ischemia, if you reverse that ischemia early on, the cells have the ability to make these outpouchings. And these outpouchings will have some components of the cytoplasm. And actually, if you reverse this early on, this B.B.S can actually be reabsorbed into the cell. And if you don't reverse it, then these components get released into the circulation. So you get that a very high elevation in troponin, very low elevation. Within 2 to 4 hours, troponins go up and down. And this is now has been proven because they were able to show these B.B.S under the microscope. Another important mechanism, which is also relevant to our practice, is the effect of increased preload. And obviously, we see a lot of heart failure patients. This study in particular, what it was able to show is that they were able to increase the preload in rats. They put a balloon in their left ventricles, they inflate the balloon, and by that, they increase the left ventricular end-diastolic pressure. And what they noticed in these study participants, that the calcium increases, and this leads to proteolysis. And they were actually able to show these calpins that start to work on the different troponins, and this leads to the troponin release into the circulation. What is also interesting in this study, not only that they identified these proteolytic proteins, but they were able to actually kind of find something that can actually inhibit its function. And so by adding this calpeptin to the circulation, they were able to lead to no troponin release at all. The significance of this study is shown in this chart. And so in the middle here, the middle bar is the elevated preload patients, and this is the troponin levels. And you can see that there was significant troponin elevation by just increasing the left ventricular end-diastolic pressure. In the subjects where they added the calpeptin, which inhibits the function of these enzymes, there was no troponin elevation. The other thing that this study showed is that if you have ischemia and you have high filling pressures, your troponin elevation will be significant. But if you have ischemia, but no increase in the filling pressures, then there's no troponin release. And this is the basis of some of the trials that we're doing today in myocardial infarction patients, the concept that maybe we need to unload the ventricle before with the PCI at the same time, and whether that would improve outcomes. So that's also interesting. But in the ICU, if we're giving patients a lot of fluids, at some point, they're going to have some component of myocardial injury as well. So other mechanisms that we didn't know in the past existed potentially, we didn't think it played a significant role in myocytes, is apoptosis. This is, again, in swine candidates or participants. They put an LAD balloon, they inflate it, they do a brief period of ischemia for 10 minutes, and they notice that there's increase in elevation in troponin. But what's interesting is that histopathologically, they get these myocyte samples and they showed evidence of apoptosis. Also, at the same time, there was significant troponin elevation just in 10 minutes. This is very similar to angina, because obviously for myocardial infarction, you would expect more time to lead to the damage. So brief episodes of angina, elevated troponin, apoptosis plays a role. And they were able to show with these stains the structures under the microscope that can suggest that this is apoptosis. So to summarize these mechanisms, I'm just going to say there is one mechanism, which is you have myocardial injury plus ischemia from an extended period of ischemia. So this is what happens in myocardial infarction. There's membrane disruption, cardiomyocyte necrosis. And then the other method is apoptosis. Both of these are considered irreversible because they lead eventually to cell death in one way or the other. And then you have, on the other hand, some reversible changes that can happen, bleb formation. There's a lot of studies now about cell repair in myocytes, which in the past was not thought to be possible because the heart has a low mitotic number. But nowadays, we know that there is a cell turnover in the heart, and these are reversible. We're also understanding in the same insult, you can have several of these mechanisms working together. Okay. So let's go back to the cases and see how we can link this up to everything we said. So first case was the patient comes in with chest pain, hypertension. They don't have history of coronary artery disease. They were cathed 2 months before that, responded well to IV fluids. And then we talked about the high sensitivity troponin. Here is this, what type of myocardial injury or ischemia is that? Just noting that on EKG, there's no evidence of ischemia, and there was a normal EF. So these were the responses. And what I would say is the difference between myocardial infarction is part of myocardial injury. So you have to have evidence of ischemia to call it an MI. Even in type 2 MI, ideally, we should only have a type 2 MI with some evidence of ischemia. These can be symptoms, they can be EKG changes or wall motion abnormalities. So in this patient, there was a significant delta from 44 to 66, but there was no evidence of ischemia. And so technically, you can call this at this point in time, it's an acute myocardial injury. When you have more information in the future, you can reclassify the patient. But what I want to do here is kind of show the outcome of this particular patient. And so patient improved with fluid resuscitation, was admitted to the hospital. They came in with chest pain, so they were admitted for acute coronary syndrome rule out, knowing that they had a normal cath 2 months ago, but this is a new presentation. They got a left heart cath that showed non-obstructive coronary artery disease. Eventually, because the patient had several hospitalizations, they had the constellation of atrial fibrillation, aortic stenosis, carpal tunnel syndrome. There was suspicion for cardiac amyloid, and the patient was diagnosed with cardiac amyloidosis. Dr. Garm.
So I find these cases a little frustrating. We have a cath, and the patient comes back a month later with cath. I suspect they came back a month later with still cath. And I say that because we don't serve the patient well. We're not diagnosing what fluid needs to be diagnosed, like a cardiac amyloid should have been considered earlier. And it's not like always procedure to undergo a cath. So what would be your recommendation? How do we deal with issues like this?
Yeah, absolutely. I totally agree. And I think part of this presentation is really to show that first, the reason why these things get done is because we don't have clear guidance, no guidelines, no consensus documents, but obviously we have patient experience. But I totally agree with you. And so potentially we can use non-invasive methods. If we really want to rule out ACS, we can use non-invasive methods. We can do coronary CT. But the idea is always to think broadly, because if you have this elevation troponin, you ruled out significant coronary artery disease, then kind of think out of the box and see what other things that can cause and explain this. Technically, in this patient, it's a myocardial injury. And I think eventually the team that took care of this patient thought out of the box and were able to reach a diagnosis. But I totally agree with you. And I think there are gaps of care in these patients when we look at it. But trying to use non-invasive methods of diagnosis would be one. And also just understanding that this is a big umbrella of myocardial injury. You don't necessarily have to have myocardial infarction. There are other things. So I totally agree. Thank you. That's a great point. So this is this case. The second case was this patient who came in with pyelonephritis, septic shock, had episode of hypotension and required these norepinephrines and stuff. The question was, how would you describe this troponin? The troponin went up from 60 to 70. That's about 15%. And this patient had heart failure with reduced ejection fraction. And so ideally, you want to make the diagnosis of chronic myocardial injury after 8 hours, but this changed from 60 to 70 in this patient. And I believe we didn't show a baseline troponin, but basically this is a non-significant delta. This is less than 20%. So at this point, this is a chronic myocardial injury due to heart failure. But in other points in the patient's hospitalization, this troponin might rise more. And actually, all of the options in the slide are causes of acute myocardial injury, as we just showed. Sepsis can cause it, catecholamines can cause it, preload expansion can cause it. Third case, the patient who came in with vomiting, agitation, got intubated, concern for alcohol withdrawal, and had these troponin elevations. This actually, I mean, there is no right or wrong answer. We'll go into the literature right now. And so continuing to observe, because this patient doesn't have chest pain, is possible, but we're going to touch around like what is the role of aspirin, statins, and other things. But what is also important is how did this case conclude? So this patient comes in with alcohol withdrawal. We realized that they had cardiology saw him during this admission for this myocardial injury, and they recommended outpatient ischemic evaluation. Patient goes to the community, gets 2 further hospitalizations for altered mental status, hypertensive emergency, doesn't get any ischemic evaluation during that time. And only in their 3rd admission, they come in with undifferentiated shock. Sensitivity troponins go up more than 10,000. They get an inpatient eval. And this time there is worsening EF, looked like there was wall motion abnormalities, get coronary angiogram, has a 3-vessel coronary artery disease. They also get diagnosed with liver cirrhosis, which complicates the problem, but eventually he gets PCI. Now, the outcome is after they survived the hospitalization, they did very well, they went to rehab, but over the next few months, they had 1 or 2 admissions. Eventually, they had complex tachycardia, GI bleeding while they were in DAPT, and they are deceased. And what you can say is that maybe the earlier we would have detected this coronary artery disease, the earlier the better. So there's definitely a gap where we can improve outcomes for patients. The other thing that I want to say is that I showed 3 different examples. One that died within the next few months. One had amyloid. These are patients with structural heart problems that are just moving around in the community. And when they come to the hospital, they come under our microscope. And so we should use that opportunity to diagnose them. And it's not only an inpatient problem, as we're just seeing. Like this patient was managed relatively okay the first time, but they never got any cardiology referral or workup as outpatient. So myocardial injury in critically ill patients is not just an inpatient problem. We have also an outpatient problem. So what are the barriers for better outcomes in these patients? And I'm just gonna go through, I want to talk about diagnostic challenges. I want to touch upon treatment challenges, outpatient care, and knowledge gap. In terms of diagnostic challenges, so now because of this, I'm just like talking about the definition of myocardial infarction, and this is intentional because I don't want this presentation to be about myocardial infarction. We don't want to be tunnel visioned, but in order to have a diagnosis of myocardial infarction, you have the acute myocardial injury with an elevation and decrease in troponin, but you have to have some sort of evidence of cardiac ischemia. And this can be challenging because sometimes you cannot prove ischemia until later on during the admission. And so that kind of makes it more complex. But the guidelines say that the evidence of ischemia are either patient symptoms, EKG changes, and not the non-specific changes, but the STEMI or non-STEMI, wall motion abnormalities, or obviously if you show a thrombus with some sort of imaging. So when we see these patients in the hospital, and this is a common problem, not only in the ICU, but on the floors, but I'm just going to talk from an ICU perspective. When you have elevated troponins, you're going to start with a really wide differential diagnosis. But one thing that can help is always that the higher the troponin level, the narrower your differential diagnosis becomes. And so, for example, the last patient, when they had 10,000 nanograms per liter, this usually happens in the setting of ischemia, either that there's a plaque rupture or that they have like no plaque rupture, but significant narrowing in all their coronary tree. And so in these very large elevations, you think about either MI, I would add to it, type 2 MI can have such high elevations if you have significant 3-vessel disease or significant coronary artery disease. Myocarditis and also stress-induced cardiomyopathy can have that. But just kind of keeping that in mind, the higher the troponin level, the more predictive it is for myocardial infarction in general. So things to keep in mind when looking at these patients, the priority in the hospital is always to rule out ACS. But once you rule out ACS, that's not job done. There's still more work to do that can be done inpatient or can be done in outpatient. One thing that is also very important, if someone has coronary artery disease, significant coronary artery disease, they come to the ICU for whatever reason, septic shock or whatever, the plaque rupture actually is not common. Just statistically, plaque rupture is not common. And for whatever, this is still not well understood, but some people think some of the inflammatory, some markers might be protective in this setting. It's not understood, but just in observational data, plaque rupture is not common. It's an opportunity to pick up undiagnosed triple vessel disease or 2-vessel disease, but plaque rupture per se is uncommon. So type 2 MI, the one thing that this whole slide is about type 2 MI, but it's again, rise and fall in high sensitivity troponin. It can present with STEMI or non-STEMI, but again, STEMI is very uncommon. So if you have STEMI, most likely they do actually have plaque rupture. And as you can see here, a lot of patients with type 2 MI have coronary artery disease. And I think in one study, it was 60% of the patients who had a type 2 MI ended up getting cath. They had 50% or more stenosis in 2 vessels. Treatment challenges. I think also pointers. So if someone in the ICU has clear STEMI, then you just treat the STEMI. If there's high risk features that suggest NSTEMI, then again, you just go per the ACS guidelines. However, the problem becomes if it's not a STEMI, and then you're stuck. Is this a myocardial injury? Is this a type 2 MI? Is it a type 1 NSTEMI? And does it even matter? But again, the things that we said, degree of troponin elevation is associated with worse outcomes. The ST deviations, the worse the ST deviations, the more worried you are that this might actually be a type 1 NSTEMI, and that could push you to heparinizing the patients and kind of expediting an ischemic eval. And then obviously in a lot of patients, the risk of patient of bleeding might preclude you from doing a lot of these interventions. Now, there's lack of data of how we should treat type 2 MI per se and myocardial injury. But the common theme is that you need to try and reverse the supply-demand mismatch. So if there's anemia, you need to fix it. If you're giving a lot of norepi, always review the doses of the pressors that you're giving. Maybe we need to come down on this on the pressors. And then the role of medications is really weak, but this was a study that was done on patients who were discharged from the hospital with a type 2 MI or also like Myocardial. And they were started on all of these medications, and you can see the separation of the curves, mainly for statins and ACE and ARBs were kind of the best. DAP didn't really change a lot, beta blockers a little bit. A lot of people in the hospital, sometimes they would say, I might start them on a beta blocker. You see this commonly done, which probably is not accurate, but statins are a low-hanging fruit. They don't have a lot of side effects. You just check with the pharmacist, make sure that there's no contraindication, especially with liver problems and stuff, and you can start it. So I'm just going to summarize these challenges. And this is particularly for ICU patients. The symptoms are unclear because they're intubated, sedated, they're getting analgesic medications. They're not going to be able to tell you that they have chest pain. Okay, we see this a lot in the medical ICU. You always want to try to think of it in a different way. Any sudden change in vital signs could be a symptom of ischemia. And so if you're trying to get echo or EKG, if you have sudden changes in vital signs, this might be a good time for you to get another EKG or a bedside ultrasound. You might be able to pick up some ischemia at that point. Okay, outpatient care. And I think we highlighted a little bit in one of the patients who had delayed testing, but this is a problem nationally. Again, we're saying that you need further cardiac eval as outpatient, so the job doesn't end in the inpatient setting. Accurate documentation of diagnosis, we'll come to this in a minute. And I think one of the things is that we don't have dedicated either clinics or pathways to follow up on these patients. So we ruled out ACS as an outpatient. What happens as an inpatient? What happens when they go back to the community? So there is probably an area for improvement there. And this is just a study from Boston. It was patients who had myocardial injury or type 2 and STEMI in the hospital. And some of these patients were seen by cardiologists, seen in the blue color, and some of them were not seen by cardiologists. And when they left the hospital, they looked at how many patients saw cardiologists outpatient, got evaluation. And patients who saw cardiology inpatient, that translated into seeing cardiologists outpatient. It translated to them seeing doing their tests earlier. But there was a significant gap. Patients didn't get any sort of evaluation for 40 days, and some had even 6 months. So again, an opportunity for improvement there. Knowledge gap. The knowledge gap, the problem with this group of patients is heterogeneous. Some of them will have underlying coronary artery disease extensive that is undiagnosed. Some of them have other structural heart problems. Some of them have vasospasms, and some of them we might not know until 10, 20 years down the line. So it's a heterogeneous population. Can't do anything about that in particular. This is not a patient population that will be able to do clinical trials. So most of the studies that are coming in this arena is from epidemiologic studies and databases from hospitals. Now, we don't have guidelines or expert consensus documents. There are some good papers, but we don't have guidelines or expert consensus documents. Part of the problem was the ICD coding. And so we also want to highlight, this is our role, how we can do things better, is that we should be able to code better for these patients. So from 2017, there has been specific coding for myocardial injury, and there's been a specific coding for type 2 MI. And there is obviously a difference. So don't say that this is a type 2 MI if there was no evidence of ischemia. So then we can have more granularity in the data that we have, and then we can follow up on that. So to kind of just summarize this part, more research is needed. We talked about having like accurate diagnosis, ICD coding. There's also some papers that say it would be very helpful for the software that picks up the diagnoses if the discharging physician says, this is type 2 MI due to atrial fibrillation or due to GI bleeding, that would also help. And then inpatient management is very important. But again, plaque rupture is not common. But also, very importantly, this piece that there's still more work to do as an outpatient, and maybe we should find pathways in that regard. Since I have a few minutes, I'm just going to kind of mention this possible algorithm. And so when someone comes in with an elevated high sensitivity troponin, this was mainly in ICU setting, but it can apply also to non-ICU patients. The first thing is look at the troponin trend to make sure that this is not chronic myocardial injury. If it's a chronic myocardial injury, you can be assured that you can take care of this as an outpatient. And this also highlights that it's also important to always go back to troponin trends in previous hospitalizations. And on the other hand, if the patient is having acute myocardial injury based on the trend that we talked about, then the most important thing is to see if they need to go to the cath lab for a STEMI or not. So you want to rule out STEMI. That's usually not difficult, but the difficulty comes in if it's not a STEMI, but there are changes that are concerning for an STEMI. So if it's a STEMI, you're going to treat that. If you have other EKG findings, this is where you have to be kind of play risk versus benefit, but use the data that you have. So do echo, go back to previous CT scans, see if they have any coronary calcifications. If you're concerned about true ischemia, plaque rupture, you might find that the EKG changes is lining up nicely with the wall motion abnormalities, lining up nicely with the CT coronary calcifications, and that might push you towards this could be type 2, but it could be an NSTEMI type 1. Maybe I'll just heparinize and take it from there. But either or, you have to treat the cause of the supply-demand mismatch. So, and we talked about these things, pressors, steroids, fluid status, cardiotoxic agents. These all should be revisited. And once you do that, if the patient doesn't really have any wall motion abnormalities, very non-specific EKG changes, this is probably acute myocardial injury. And then again, highlighting that there's more work to do as an outpatient. If there are regional wall motion abnormalities, this can be type 2 MI, but it can still be a type 1 and STEMI. So again, you look at these things and then decide if the patient doesn't have contraindications, you might want to treat it as a type 1 and STEMI and maybe get some sort of an inpatient evaluation. And again, the patient eventually is going to need some outpatient follow-up. This was an attempt by me several years ago and then maybe in the last few months, but that kind of shows you we don't really have any guidelines. We don't have any documents. So this is just one person. It takes a village. So the take-home points are that patients with myocardial injury have worse short-term and long-term prognosis. This is irrespective of whether they have coronary artery disease or not. Focusing on the longitudinal care is very important because it offers a unique opportunity to unmask structural heart disease that we can, as a health system, we can unmask. And the gaps in the medical care, we talked about some of the gaps, talking about lack of guidelines, accurate ICD coding, and et cetera. I will thank Dr. Davis and Dr. Mose for giving me this opportunity, for kind of giving opportunity to fellows to come and present what they're interested in. I prepared these slides many years ago with Dr. Jaffe. He's an expert in troponins, and I wanted to just acknowledge that. And obviously my co-fellows, because all the cases that we presented today were cases that were from the fellows. So thank you so much for that. And thank you for the support. Like everyone was just like sending me text messages and supporting me. So thank you so much.
Thank you, Abdel. That was a phenomenal presentation, very comprehensive. You know, as always trying to understand how things work.
Thank you.
I have a quick question for you. And, you know, you've clearly shown that the higher the troponin, the worse the outcome. And my question was, do we have an understanding if we think that this is due to the underlying cardiac kind of disease? Is there any information showing that maybe troponin itself it can be responsible for further damage? And if that's the case, is there any potential treatment options targeted to troponins?
Yeah, that's a really good question. The first part is that obviously there are a lot of patient populations where there could potentially, there are antibodies against troponins that can change the values of troponins. There are certain patient populations that I didn't talk about, including stress-induced cardiomyopathies, kidney dysfunction patients where we're trying to understand more. As far as I know, I didn't come across studies that show that troponin itself has a deleterious effects on others. I think most of the studies in the literature talk about it as being just a cell component that gets released into the circulation. But that's a really great question, but I'm not aware of any studies. Thanks.
Dr. Eagle?
Thank you very much. I really enjoyed your talk. It's wonderfully presented.
Thank you.
Sometimes I feel like the term myocardial injury is an overstatement. Sometimes I think it's just a release, right?
Yeah.
10 to 20% of marathon runners had elevated troponins when they finish. Many of them feel a little out of breath, and they release the troponin. I'm not sure they've had a significant myocardial injury. I think they've released troponin, and maybe that
So you can kind of look, I put it as
compared to something doesn't, but we sort of, I think, straying toward that term, and I'm not sure it's a good idea. There was a guy named Bob Jesse who ran the VA cardiology for the nation, who once said that when troponin was a poor assay, it was a great test.
Yeah.
And when it became a great assay, it became a poor test.
That's very true.
Was taking troponins all over the hospital all the time.
Yeah.
So I think we have to be careful about the term myocardial troponin release versus injury, and dig deeper into these patients where there's no clear evidence of ischemic event, but clearly their heart muscle isn't responding to stress, perhaps the way the average does. Lots to do there.
Yeah, thank you, Dr. Eagle. Yeah, that's a really great point. And I was actually thinking about this when I was kind of preparing these slides. And I think the problem has kind of, it's compounded by the high sensitivity troponin specifically. And I wondered if at some point in the future, we might say, okay, maybe in certain scenarios, we should not use a high sensitivity troponin. So it's going to be like some sort of a regression to the mean type of. And that's really a good point, because as I highlighted at the beginning, there are people with normal, completely healthy, presumed, with some elevations in troponin just walking around. And are you going to call this myocardial injury or not? That also comes to the fact that the fourth universal definition of myocardial infarction has not been revisited in a while. And so I think they're soon going to be talking about it again. But I think that's what I'm thinking, is that are we going to revisit these definitions so it can be more clinically relevant? Then, because definitely there is some burden on the health system also, just kind of chasing these, and for the patients as well, sometimes worrying them. So I totally agree. Maybe there will be some sort of regression back to the mean somehow. So yeah, maybe the all troponin is not dead yet. Yeah. Thank you.
Yeah, really nice talk. You showed quite nicely that catecholamines, even in healthy individuals, can elevate troponins and kind of related kids. Question as well, is there any data suggesting that patients who are that come in on beta blockers, that elevated cardiac troponins or the delta that is more diagnostic in those settings because their sympathetic system blocked, they still have high troponins?
Yeah, that's a really good point, specifically because we know that the effect of increased sympathetic system on the heart is generally not good in the heart failure population, stress-induced cardiomyopathies. And oftentimes we do send these patients on beta blockers. I don't know if there was a study on the reverse. I didn't see that, oh, patients who are coming in with beta blockers, they had significantly lower decrease in the troponin. So that's an interesting thing to look at. I am not aware of such a study, but it obviously maybe someone thought of it and did it. But I think this is a good point. We're going to still hit that heterogeneity when you're studying that patient population, maybe just focusing on one group of patients coming in with beta blockers, maybe AFib or something, and see how the elevation in that particular group. But I think it's a great point.
I just imagine many of the patients that come into the ICU would experience a significant sympathetic challenge before they arrive in the hospital.
Yeah, exactly. And then maybe we'll find some protective effect on beta blockers or something. So maybe you gave me a good research idea. So I'll just steal it. Thank you so much.
We have one last question from Keith Aronson from the virtual audience. Keith, do you want to ask your question?
Yeah, thanks. Do you guys hear me? Can you hear me okay?
Maybe not. We can hear you.
You can, okay. So first, Abdel, it was a spectacular presentation. Your presentation skills blow me away. But my question is, there's studies showing that athletes, if somebody running hard on a treadmill
Well,
increases
I
their.
think we have some technical challenges.
No problem.
Um,
Thank
Oh,
you
you're
so
not
much.
hearing me.
Thank you so much
Thank you.
for being here.
Thank you. Thank you so much. Thank you for attending this thing. So much. Appreciate it. It was fun. I'm gonna leave the meeting, right?